Welcome, and thank you all so much for attending our town hall tonight, covering the CMS cuts. My name is Benjamin Pierce. I'm faculty in academic practice at the University of Alabama, Birmingham. And I believe my good friend Matt Seidman asked me to host tonight, as I likely represent many of you in the audience. I am passionate about vascular surgery, vascular patients, and all the ancillary folks who work hard every day to make our jobs possible. However, when the talk turns to cost over inflation, MIPS, MACRA, conversion factor, and et cetera, I take on sort of a postprandial soporific state. But I know that this issue is vital to all of us, and I hope I can be an adequate conduit to our membership to get their questions to our experts. First, just a few housekeeping reminders. Please use the Q&A button at the bottom of the window to ask your questions. In fact, we're going to record the chat, and we have a hard stop in 90 minutes, but we are going to try to answer the questions we can't get to on SVS Connect over the coming days. We'll also be answering some questions that were pre-sent in by you, the SVS membership, in tonight's town hall. So please ask questions. This is meant to be for you. We plan to keep the didactics to a minimum and focus on your questions. I'd like to get the ball rolling by introducing my good friend and former partner, Matthew Seidman. Matt is the co-chair of the SVS CMS Cuts Task Force, chair of the Advocacy Council for the SVS, and our representative to the RUC Committee. He currently practices in a hybrid academic model at the UT Health System in San Antonio. Matt, I want to welcome you. Thank you for your excellent leadership on this topic, and I know it's weighing on many of our minds. Matt, the Zoom is yours.
Thanks, Ben, and thanks for agreeing to host for us. I'd also like to thank everyone for coming tonight and registering, and hopefully this will be informative for you. I'd like to also thank our panelists, and we'll start with an introduction of the people who will be speaking as our content experts tonight. First, we have Dr. Sean Lydon, who is chair of the SVS Government Relations Committee and chairman and professor of vascular surgery at the Cleveland Clinic. Dr. Mark Matos, who's co-chair of the SVS PAC Steering Committee, as well as a board-certified vascular surgeon in private practice at the Michigan Vascular Center in Flint, Michigan. They're a self-employed vascular surgery practice with over 110 employees, 9 vascular surgeons, 4 NPs, and 2 vascular PAs. They work at multiple hospitals, 2 OBLs, 2 ASCs, and an outpatient vein center. They also run their own ACGME accredited vascular surgery fellowship training program, training 3 fellows per year. Dr. Dan McDevitt is chair of the SVS Community Practice Section in private practice with Peachtree Vascular Specialists in Atlanta, Georgia. And Dr. Megan Tracy, who is vice chair of the SVS Advocacy Council, past chair of the SVS Government Relations Committee. She received her MD-JD from the University of Illinois and is in academic practice at UVA in Charlottesville, Virginia. So I'm going to go over a little bit of the problems that we're facing. And one of the biggest issues is that we're facing cuts of multiple different types from multiple different parts of the Medicare fee schedule that all cumulatively result in about a roughly minus 12% impact for vascular surgery overall. However, the degree of that impact varies based on your practice setting, hitting our colleagues that practice in an office-based setting the hardest. So there are 3 types of cuts that are affecting specifically vascular surgery and all vascular surgeons in general. The first is that there is an expiration of legislation that gave us relief from the conversion factor last year. This is going to result in a minus 3.85% reduction in payment starting January 1st, 2022. The next that specifically affects vascular surgeons is that 2022 will be the final year of implementation for an update that Medicare did for supplies and equipment. This results in a 4% overall reduction in payment for 2022. But again, if you own your own office and you purchase your own supplies, this is going to have a higher impact on you in particular. And lastly, specifically driving vascular surgery down is a new proposal that came out in July of this year in Medicare's proposed rule for the physician payment for 22, which is an update to the clinical labor staff payment rates. So these are the payment rates for your MAs, your front office personnel, your people that answer your phone, your scheduler, your coders, and if you own your own office, your nurses, pretty much anyone that you pay as a laborer for your practice. Those rates have not been updated since 2002. So it's been almost 20 years since they updated the hourly wages for these employees. The result of that is about a $4 billion increase in expenses to direct practice inputs. And that is then, I'm sorry, to indirect office inputs. And that then is offset by decreases in payments to direct supplies and direct practice expense to the tune of about $4 billion. And that increase of cost is what was driving vascular surgery down by an additional 4%. One of the changes that we've been able to impact on Medicare between the proposed rule and the final rule is that they've decided to do a 4-year implementation. So instead of getting an overall 4% cut on January 1st due to the clinical labor staff payment updates, it will be a 1% cut in January, but a 1% cut each year for the next 4. Can we have the next slide? So more bad news on top of that, that is facing all physicians across the country, includes sequestration, which is an additional 2%, direct 2% cut, pay-go, another 4% cut on top of the other 3 we just talked about. This leads us to a little bit of a differing opinion with CMS, because when CMS published their rule last week, they project that vascular surgery overall impact to be a -5%. When we add all 5 of these up, we don't get 5. We get -12.75, pretty close to that as an overall impact. But again, that impact is going to vary based on your practice setting, with providers who function mostly in an OBL seeing individual code cuts as high as 22%. Next slide. So a little bit on the sequestration moratorium that's going to be expiring. So sequestration is an effort to control the budget, and it came out of the Budget Control Act of 2011. So what it does is mandate more than $1 trillion in cuts over 9 years from 2011, and it required a 2% annual cut to all Medicare payments. It was in effect before. It's been delayed twice by Congress, starting with the CARES Act, delayed it through March 31st of this year, and then that was extended through December 31st, 2021. But it's important for everyone to understand that the moratorium on cuts is expiring, and sequestration will kick in again on January 1st unless Congress acts to put it back on hold. Next slide. Pay-go is another Congress statute that is triggered when spending and revenue legislation increase the federal budget deficit over a 5 to 10 year period. Pay-go was first introduced in 2010 and is reintroduced when the Democrats resumed control of the Congress. This provides an additional Medicare payment cut in 2022 at 4%. And this was triggered this past spring by the American Rescue Plan. That was the $1.9 trillion spending plan to address COVID expenditures. So by passing that legislation this spring, that triggered pay-go, which will in turn cut all physicians 4% on top of the 2% sequestration. So even without looking at the cuts that directly affect vascular surgery, you're starting off at 6% down for 2022 just because of pay-go and sequestration. So we feel that Congress needs to waive pay-go cuts before the end of the year. Otherwise, this is what we're facing. Next slide. So to just give you a couple of examples, and those of you who've been following some of our posts on SVS Connects may have seen some of these before. But if we look at some specific codes, so let's take dialysis access, for example, and we look at a fistulogram with an angioplasty, or CPT code 36902. If you're performing that in the facility setting, so if you're just doing that in the hospital, the anticipated cut, if everything goes into effect as proposed or as passed, it's right around 9%, a little more than 9%. If you're doing fistulograms in your own OBL, you're going to feel a 14% cut for this. Next slide. How about your vascular lab? Well, let's look at the most common reported vascular labs by vascular surgeons, bilateral carotid duplex. If you're doing the duplex in the facility setting, your professional fee or your fee for reading that study is going to take an anticipated 8% cut. If you have your own vascular lab that you're doing in your own office setting, that global fee is going to take an 11% cut. Next slide. Lower extremity revascularization. If you do angioplasty and atherectomy of a femoral artery in the hospital, your professional fee, 9% cut. If you do it in an OBL, your global fee is going to take an 18% cut for the same service. Next slide. Vein clinics also are affected by this. So endovenous ablation of saphenous vein, including all image guiding, your first vein treated in the facility, in the hospital, anticipated cut for your professional fee is going to be 10%. If you're doing it in your own OBL or in your own office setting, get ready for a 21% cut in your reimbursement from Medicare for vein ablation. Next slide. So because this stuff was proposed in July when Medicare published their proposed rule, the SVS responded by appointing a task force to have a multimodal approach to fight these cuts. I was asked to co-chair this committee. A lot of our leaders are on this town hall tonight, and I want to spend a couple minutes going over what we've done the last several months to try to combat these. The first phase was focused at CMS to respond to the agency directly. We started with coalition building and reached out to other specialties that are similarly in line for significant cuts, including interventional radiology, radiation oncology, and radiology itself. We took time to analyze the impact and the data for what was being proposed in the proposed rule to see where the negative drivers were and what the specific technical problems were as part of that rule that were leading to these specific cuts. And armed with that data, we wrote very detailed comment letters to CMS and met with technical staff at CMS to outline the issues and the problems as we saw them. We moved on to member engagement, and I asked for most of you to submit letters directly to CMS, and over 180 SVS members responded with their comments for us. Next slide. Moving on to phase two, we've pivoted to focus on at the congressional level. We had SVS fly-ins over the summer and circled back with those staffers to encourage support of legislation that will help block some of these cuts. We've attended multiple PAC events, and we've supported congressional members that are favorable to our plight, and some that are former physicians or current physicians themselves that are helping us with legislation to block some of these cuts coming our way. And we've continued to work with advocacy, including the Clinical Care Coalition, the Surgical Care Coalition, and the Cardiovascular Coalition, to focus on sign-on letters and dear colleague letters on Capitol Hill to get more attention for this issue among other Congress members and hopefully lead to legislation to block what we will otherwise have to face come January 1st. Next slide. So what to do next is spread the word through the vascular community. Tonight is kind of the beginning of step three, phase three, which is member education, so that you all know what is facing us and what can be done to prevent these looming cuts. Second is donate to the PAC. This is crucial for us to gain a seat at the table and for us to gain access to the members of Congress that can help defray some of these cuts and help us avoid what we're facing. And third, contact Congress. Anyone can reach out to the representative. We're going to make it very easy for you through the advocacy page on the Vascular web. You go to that and then to the task force, and it will take you directly to our voter voice links where you can contact your members of Congress and tell them to act now to stop these cuts that we're facing. Next slide. Here's that the address for you so everyone can find updates from our advocacy and from our task force and how to reach out to your congressman. Next slide. So we have had some wins in the last several months. Between the proposed rule and the final rule, we were able to get them to use a more appropriate payment rate for our angiotechs. CMS will use median BLS salary data instead of mean data to calculate the payment rates, as well as a more appropriate fringe benefits multiplier. And although we wanted no implementation of the clinical labor updates, a 4-year phase-in versus a all at once, I put the plus minus there. That's either a win or the loss column, but I'll take the positive and say that that's a win. But most importantly, there's still time to impact these cuts, but it's going to require action and advocacy from all of us between now and January 1st to avert the worst of these. Next slide. So again, donate to the PAC. The PAC needs your help. We need those dollars to get in front of the congressmen who can help us in these fights. Last year, we were successful at blocking some of these cuts and averting a significant payment reduction from the E&M updates. We'll need more of that this year. Next slide. These cuts are going to be real, and we're going to go through some of these scenarios with each of our panelists, but they're going to range from 9 to 20% loss in Medicare payment, and that's going to affect not just your bottom line, that's going to affect access to care for our patients. Next slide. That sets up a snowball effect, and I'm stealing your slide, Mark, but 9 to 20% loss of Medicare payment, that leads to loss of your staff. You're going to have to lay off some of your surgical staff, your PAs, RNs, NPs. It's a reduction of patient volume, and it affects how you can practice. This leads to delayed care, decreased care, adverse events, and shift of Medicare patients to tertiary centers, has an adverse effect on teaching, training, and research, and leads to burnout, loss of well-being, practice loss, and early retirement. This is not the snowball we want to be on. Next slide. The important part is that we are all in this together. We are working hard on averting this for all of our members. And those of you that are here listening, you have an opportunity to join us and share your voice with ours and help fight what is coming and help avert, hopefully, as much of this cut as we can. So I'm going to stop my introduction there, and we'll circle back to some of our panelists to talk a little more in detail about each of the cuts, and then also to address some of the questions that the members emailed into us ahead of time to discuss. So, Sean, would you like to start?
No, that'd be great, Matt. So, the first thing I got asked that came up was, what's sequestration? And for those of you who aren't part of the government relations committee or do this every day, like Matt went through this really fast. And so, sequestration started literally a decade ago, and it was the Budget Control Act that basically said that for federal spending, we had to cut what we spend, and Medicare would incur a 2% across the board cut, but it would be enacted over 9 years. Now, government has given us a relief on that multiple times. The most recent time was in the Coronavirus Aid and Relief Economic Security Act, or the CARES Act, in 2020, which extended that relief through December 31st, 2020. And then they gave us another 1-year release in a House bill that only has a House bill number. And so we haven't had the effect of sequestration since it was passed, but it has to be the savings of that $9 trillion over that period of time. And so, you know, at some point when they pass a law, the piper has to come due. And so those effects of that 2% come due again this year. Now, Congress has helped us every year, but a lot of it's been because the Government Relations Committee and all physicians have asked for that help. And so what can we do to mitigate those effects? As Matt pointed out, we need to get onto the SVS site, and realizing that through that, you can look through advocacy in the policy webpage and look at voter voice, and it'll pre-populate how we reach out to our congressional leaders, asking for their help to stop the effects of sequestration, either temporarily, as they have every year, or permanently. And we only really have a limited time for them to do this between now and December 31st, and they're not in session forever. And then my partners, I'm in an academic setting in the Cleveland Clinic, my partners said, well, it doesn't affect me. And I'm like, no, it does. It affects us all, whether in private practice or academics. It affects payment for all caregivers, my advanced practice providers, my NPs, my PAs. And if my department doesn't make money, then we don't get raises, and I can't hire new people, and we have cuts. And so if you're in private practice, you feel it immediately. But if you're in a situation where you're paid by RVUs or paid on a contract, you may be immune for a short period of time, but eventually comes around where when you bring in less revenue, whether it's on the office-based side or on the hospital-based side, it's eventually gonna affect you. And so this 2% affects all providers across all of medicine. Matt, you're muted.
Sean, while he's figuring that out, let me ask you a question. You mentioned voter voice is something people can do. What's the timeline? Like how much time do we have left to really get somebody to do something to suspend this for us?
And so I think the key thing is it's not just the SVS members, it's their family, it's their brothers and sisters. Any of us can get on voter voice, and you put in where you live in your area code, and it'll find who your senators are and who's your member from the House of Representatives. But these cuts go into effect January 1st, 2022. And so we have to tell Congress immediately, because if they don't hear from enough of us, they don't feel it's an impact and they won't care. So, I mean, starting now, starting today, starting tomorrow, we have to message this to our congressional leaders that we're gonna just get crushed.
When do you think that they would like meaningfully meet to do something about this?
So there really is one big last bill that usually comes around in December that they can add this on. That's what's happened typically at the end of every single year. So it's happened at the 9th hour, at the 9th minute, in the 9th inning, in the bottom of the 9th. But if we don't start getting them all excited now, there will be no groundswell to make it happen.
But I guess that's my question is, don't you think folks are used to every year? This is where we've been delaying this pretty much on an annual basis, ad hoc, year by year. At what point does the people just think it's going to happen again and they don't get involved? You think this is the year?
I think people fatigue of that, but at the end of the day, you know, every year it may have been like last year, we were worried about like a 9%, potential, and it came to 4%, and we fought it and got it suspended. Like this year, if you run OBLs, you're going to plus 20% pay cut. That means shutting the doors. And, you know, people say, well, they'll just get care in the inpatient setting. I mean, maybe your hospital is different than mine, but we don't have enough nurses to provide that care. I mean, we're talking about delaying cases on a daily basis because there's such a shortage of personnel. And so I don't think it's ever been this dire in my entire practice career since I started in 2001.
All right, I found my unmute button. You would think after 18 months of Zoom meetings and COVID, but it seems like that's a common pitfall. Sean, thanks for your expertise and all your work on the government relations. I see lots of questions rolling in here through Q&A and on the chat, and we're going to do our best to answer all those. Mark, you want to talk a little bit about the conversion factor? Sean was alluding to that, of what we averted last year at the very end of December with that last last bill that gave us the 3.75% relief. So have a little more detail on that for us.
Yes, thanks, Sean. Welcome, everybody. This is a great venue. We have 150 people on the chat. I mean, on the town hall. So, you know, my job is to try and explain a little bit about the conversion factor, because bottom line is you cannot send a message to your congressmen and congresswomen or talk to them unless you have accurate data that which you can actually support your arguments in them. And the overall argument based on the conversion factor is that they don't value what we do and have not valued what we do since 1996. If you don't know, let me just give you a little background. So each year Medicare puts out a physician fee schedule where every procedure we do is given an RVU value. And that value is converted to dollars. And that's how we get paid, either in a private practice, a dollar amount, or based on RVU if you're in a different system. The conversion factor last year was $34.89 per RVU. Their plan is to change that and drop it to $33.59, which is $1.30 per RVU, which may not seem much, except if you're doing 10 to 20,000 RVUs a year, which means that that's a 10%, 9.6% drop in your income, period, off the get. No matter how hard you work, no matter how little you work, it's an automatic 10% drop. You have to understand that the driving force for dropping that number is based on an increase in the money provided for primary care for E&M codes for doing the same work that we do, but they get paid more, and you have to balance that out. The result is, as Matt said, it's a $3.5 billion change in revenue from specialists, us, to primary care in the office-based setting. Last year, we had a 3.75% relief based on the Consolidated Appropriation Act, which was done because of COVID and because of the adjustments that were being made in 2021. They wanted to give us 1 year to try and adjust to that. You have to understand that we don't have COVID as an excuse anymore, and they're not giving us another year to adjust. They're going to take our money and take our ability to take care of patients in a cost-effective manner unless we do something about it. So if you look at our conversion factor in 2021, we're getting paid the same amount of money as we were in 1996 based on inflation, which means that the actual loss of inflation-adjusted income and ability to take care of our patients in a cost-effective manner ranges from 20 to 40% decrease. Now, I don't know about you, but I'm unhappy about that. And all of us on this chat should be unhappy about that. Nobody in this room should go home and say, oh, well, that's business as usual. Everybody on this chat should go home with a scorecard about how to get there in front of their congressmen and congresswomen and say, this is not right, this is not fair. But you have to know these numbers to be able to talk about that. And I just think that we were lucky last year that we all together worked hard to get these cuts, and we're going to have to do the same. My partner, Rob Molnar, put in the chat about we need a timeline, and that was answered by Sean, but we have a limited window to have an effect. And hopefully by the end of the night tonight, you'll have a good idea about how big that window is and what we need to do. All of us have to get this done. We have to go through Congress to effect change, particularly as it relates to the CMS decision. We don't have an opportunity to go to CMS, and Matt and others, Megan and Dan, can talk about that. But we only have one option now, and this is phase 2, phase 3, as Matt has talked about, to be able to make this happen. You know, that's It's a little bit like the movie Network in the 1970s. I'm mad as hell and I'm not going to take this anymore. And there's a lot of people on the chat saying that. We need to look at that. Nobody should devalue what we do. We're the one specialty that should not be devalued, and we need to make it work. So,
Mark, can I highlight something you said that I thought that actually people have been putting in similar sort of theme in the chat? You talked about how the E&M codes, right, have gotten changed for primary care to boost them up at probably at a sacrifice to specialists. How is it that we're not getting how's it we're not be able to offset some of our losses with E&M codes? We're providing a lot of primary care service as vascular surgeons, and we're coding a lot of the same codes as primary care. How is it that that's getting lost to us?
Ben, it's a great question. I might have to ask Matt to step in on that one because he's worked on it a lot more in depth than I have, and from that point of view. So, Matt, can you help me with that? Yeah.
So the Medicare is basically kind of set up a little bit of a two-tiered payment system for the same type of work for the office work. And that has happened through our global surgical payments. I used to hear a lot when I was in training that, Medicare doesn't pay me for post-operative care. And as I got more active and involved in the advocacy, I learned that no, they do pay you for post-operative care. They just pay you a whole lot less for the operation than you think they're paying you. So in those 90-day globals and 10-day globals, there are typical visit patterns built into those payments that that the typical average surgeon would be providing. Several years ago, there's been a little bit of a split. This has been going on for the last 5+ years or so, where CMS doesn't believe that we are providing that post-operative care. And so when the E&M codes were revalued several years ago and got increases, which resulted in a shift of about $3.5 billion into primary care office visits, those same values for those visits were not translated into the global packages. So they have in effect set up a two-tier system where if you're a primary care doctor and you're seeing people in their office and you're billing E&M visits, you get paid at one level. And on an aside, because a lot of the work that we do is outside of global periods now, as we do a lot of endovascular work, we get paid that exact same rate for people we see in our office. However, when we do something, when we operate on somebody and we're providing post-operative care in that global, the value of those same visits in the global period are at the previous values. So it's undervalued right off the bat. And that's an unfair system that's been set up and is now being perpetuated as we keep moving forward with that.
Since all things in these arenas are semantics, you said something like we aren't valued in the global. You don't really mean we vascular surgery, right? It's surgery, big surgery.
Big surgery.
The global big surgery. And so I think that leads us into a couple other things that people are asking in the Q&A, Matt, and we can go to different people to answer it. But, you know, I think that's sometimes lost in us. Like when you say we, the vascular surgery, we think we're special, right? I mean, that it comes out, we should strike, we should do this because we provide something nobody else does. But they don't look at this on a specialty by specialty basis, right? They see surgery. Is that a fair way to put it? And so, Sean, you had mentioned in our private chat that there are some efforts we've been doing with the other surgery group that have benefited us. Would you like to sort of speak to that for the crew?
So, you know, the two things, one, you know, the first thing we all heard that sit in the leadership of all these committees is that the SVS doesn't represent everybody. And so whether you're in a private practice or an academic practice, we tried to reach out to everybody. So the SVS has reached out to the cardiologists to do this, the radiologists do this. There's an OBL society that we've asked them to be a part of our task force. We've reached out to SCI, we've reached out to ACC, SAR. Matt and Megan have been tireless in cooking us together. Ken Slaw, as a representative for our society, has reached out to the leaders of these things. The other thing is from the surgical society, there's something called the Surgical Care Coalition. that looks at the cuts for surgery in general. So the things that don't affect the office-based practice that maybe the cardiac surgeons don't see, to really get everybody together, look at those cuts that affect everybody in general. So I think the one thing we've tried to do as a society is to touch anybody else this affects. And so, which you might not think is like, well, the ophthalmologists do some office-based procedures with high practice costs, they're affected. The cancer doctors have some office-based practice, they're affected. So we really tried to touch anybody else this affects, because the bigger the voice there is in medicine to reach out to our governmental relatives to help both on what they can affect for sequestration and PAYGO and what they can force CMS to do for the CMS proposed rule. It's basically, we're getting it from all sides, and we've tried to touch everybody we can to help us out.
So maybe, so then Megan, can I ask you a question? You know, when he says we can reach out to Congress, I mean, with all these other people, at the end of the day, that means through lobbying and PAC funding. Is that too simple?
No, thank you. My office thinks I'm not active enough.
You involved, there
so,
we go.
No, that's not at all too simple. So it's an interesting thing. I'll tie it back to Matt's overview of all the different parts of this problem. So I think the simplest way to support SVS advocacy and surgical advocacy in general, of course, is to support the PAC. I mean, that really gets our voice into the room. It gets our advocacy staff, it gets our members, it gets our leaders into the room with members of Congress and their staffs to really advocate on our issues. The more complex answer to it, and this also goes to some of the questions on the chat with regard to the timeline and what's going to be asked of our members in terms of the grassroots, is that each piece of this fix is essentially a separate legislative fix and a separate coalition. So the sequester relief and PAYGO, these things that were essentially statutorily mandated across the board cuts linked to overall spending, and boy, have we seen a lot of spending, and are we likely to see a lot more spending in the next few months of this year. Those obviously have a broad coalition, you know, across all of medicine. The conversion factor relief has a broad coalition across all of medicine and certainly surgery. So there will be grassroots efforts linked to the surgical care coalition, such as these congressional sign-on letters that so many of you advocated for, asking members to support legislation for conversion factor relief. The clinical labor coalition that again has with Congressman Rush, offered legislation to fix very specifically or stop the implementation of these cuts linked to specifically the office-based procedures. Again, will be, even though it may move in that one bill at the end of the year, it'll be a separate legislative piece, a separate coalition with those groups that Sean just mentioned. Again, it'll be a separate letter, separate ask in the grassroots. So it's going to be a really interesting time over the next 6 weeks to be looking at these very, very fast moving asks, and they will be coming through Connect. They will be coming through email. They will be coming through, outreach to all of you, and they will be available on the website. So all of those things will be important. I think an interesting point, and it's coming up again in the chat as well, is this going to happen every year? What are we looking at going forward? What does this mean? So can we look at that slide 6, that CPI slide? So I think it's the next one down. Overall, is this problem going to go away? No. I don't know if we may not have it in this set. In any case, if you go back 25 years, we haven't kept up with inflation. And this CPI adjusted slide was developed by the American Academy of Ophthalmology as part of the Surgical Care Coalition effort. But ultimately, what it shows is that every other player in healthcare has been in there fighting hard and has at least kept up with inflation. The hospital inpatient, the hospital outpatient, skilled nursing homes. If you look at pharmaceuticals and devices, all of these things have, except physicians, over this period of time. So I think we're very rightly doing this rapid response and focusing on these individual skirmishes that need to be fought over parts of this. But ultimately, yes, I think many of you are right. There's a great broader perspective here and probably a broader fight. And a lot of the answer to that, in all likelihood, is going to be figuring out what the coalition is that keeps all physicians together and keeps all surgeons together, because ultimately that hasn't happened effectively in 25 years and is something that I would anticipate will need to happen effectively going forward, and is something that the SVS is actively engaging in exploring and discussing. And certainly all of your input is welcome on that front as well.
Megan, this is great. I want to expand on something you said in a two-part question. One, I think you gave some people like a playbook, right? What can the individual who's watching tonight do tomorrow? There's multiple coalitions, and what you're saying is when we get asks through SVS Connect or email or whatever to write a letter, it may not be always the same letter. Like if I logged on and did it at BAM when I got real excited after listening to Matt talk at BAM, that may have been for one thing, and when you get it back again, it's not the same thing all over again. That's the first question, is trying to get a playbook thing. The second is when we do these asks, somebody asked a really great question about, we keep every year is suspending the cuts, but it never addresses cost over inflation. Are we not asking for the right thing when we every year we have to go through this again? Should we be asking for an inflationary adjustment in addition to suspending the cuts?
Absolutely. And there's absolutely no reason that this looks like a survivable curve over the next 20 years. I don't know about you, but I plan to be working over about that period of time. So it matters to me a lot, to the people that we're both going to be recruiting over the next couple of months into our programs and launching their careers. It's critically important. So yes, each ask is going to be probably a separate part of this fix. And there may be a overarching ask as we push for whatever we can get included into that last piece of legislation that moves this year. Do we anticipate we'll win all of them? No. I mean, I think it'll probably be a mixed bag. And obviously the lift is a little bit easier the larger the coalition and the broader the coalition here. But the SVS and its membership have done really unprecedented work in terms of finding and building really creative, smaller coalitions going forward, and pushing hard and effectively on these issues where we've nominally been kind of singled out. I do think an important point in all of this goes back to some of the work that we've actually been supporting as part of the Surgical Care Coalition, which is right now a 13-member surgical group of surgical organizations, really looking at not just at this, but actually at the bigger picture. How does the public perceive us? How do policymakers perceive us? And there's been some interesting survey data that have been gathered at a couple of points through this campaign starting last summer. And it's an interesting thing. So we worry a lot about how we're perceived by policymakers and by the public. We worry a lot about people confusing the reimbursement for our services or the valuation of our services with our income, when ultimately, particularly for a lot of the private practices, this ultimately means your building lease, your equipment, your staff, keeping the doors open and the lights on and services available to patients. In the academic setting, or the employed setting, people sometimes mistakenly feel that they're a little bit insulated from this, but ultimately, yes, it goes to how many people you can support in your group. It goes to all the other parts of your mission, education, research, that protected time that you can't figure out quite why your boss is mean and won't give you a day a week to think big thoughts. Well, we can't afford to do that if we keep losing ground on this front. So what have they learned in doing this surveying? Ultimately, the public likes us. I think they think that we're incredibly well trained. We have a unique skill set. We work incredibly hard. They do think we drive fancy cars. They're not super sympathetic to the idea that we're facing plight in this regard. But if you look at who they like less than us, it's a lot of the other players in the healthcare market. They don't like hospitals or hospital executives more than they like surgeons, and they certainly don't like insurers. That said, those two players have been out there lobbying incredibly hard and actually doing very well over the last 20 years, while we've been very shy about this in a lot of ways and losing the fight. So I've said before, and I'll say again, in terms of endangered species, we're the charismatic animal. I mean, we're the lion on the savannah here, facing extinction. We're not the mud bug. We're not some insect that lives under a rock, and we should be able to make that case. So I think that some of the data that's being marshaled by the Surgical Care Coalition, again with our support, is going to be really critical to taking a step back and maybe taking a new look at how we're approaching the broader fight, and looking at whether it's acceptable to continue giving up small pieces of ground every year. Ultimately, over the long term, it is not.
Thanks, Megan. I appreciate all your perspectives and the work you're doing with us with the Surgical Care Coalition. Dr. McDevitt, I was hoping that you could tell us a little bit with your perspective as a private practitioner, how you foresee these looming cuts affecting your practice, and maybe expanding a little bit on the clinical labor update and supplies and equipment cuts.
Yeah, thanks, Matt. I appreciate it. This is interesting. The clinical labor part, we're kind of getting into sub-formulas of the RVU principle. As you know, just for everybody to understand, the RVU system, which was started in the early 90s, was actually an economic solution that happened to be applied to a medical system like we have now. So it's a fairly intricate formula. RVU is composed of three components: the physician work component, the practice expense component, and also the malpractice component. And the middle one of those three, the practice expense, also includes what CMS calculates as salaries and other overhead expenses that are normally associated with the practice. And as Dr. Seidemann had indicated at the beginning of the presentation, they really didn't update that for about 20 years. I guess it's a little bit of an oversight, but you know, for physician practices that depend on E&M codes in particular, obviously you could see where, you know, salary increases, practice overhead increases, leases, EMRs, office equipment, et cetera, continued to expand over that time, and there was really no substantial update in the amount of money that was being pumped into that. So they decided to update that, and actually this year they wanted to update it all at once with a 4% increase. Well, Medicare is a pie. They don't have their own money. They get allocated a certain amount of money from Congress. So if somebody's going to get a slice of the pie that's bigger, somebody else necessarily has to get a smaller slice of the pie. And that's what's happened with the clinical labor payment, is that they wanted to update the salaries of techs, MAs, nurses, et cetera, but they needed, I believe we calculated somewhere around $4 to $5 billion to do that. Well, the place that they came up with the $4 to $5 billion was actually pretty much the procedure codes that involve vascular surgery and IR. So as a specialty, or as a like a, you know, care specialty, if you want to include the IR in there, we're paying for all of this. It really wasn't distributed around the entire physician force. It was more or less focused on us, and it's more focused on the outpatient setting, because that's where a lot of the expense is for physicians. So anyway, how does that affect what we have going on? Well, obviously the amount of money that's being allocated to pay for in-office procedures is dropping significantly. As we discussed earlier on in the seminar, some of the cuts are as much as 20 to 22% for some of the procedures that we normally do. There are very few businesses in the United States that can tolerate an immediate 20% cut in their revenue overnight and still survive. And that's because most businesses have fixed expenses as well as variable expenses. And those fixed expenses are usually contractual expenses like loans, build outs of OBLs, leases, et cetera, that you can't terminate in any short period of time. Now, we're looking at these cuts starting on January 1st, which is less than 60 days from now. I can also tell you, based on our experience last year, Medicare is already loading this new fee schedule into their computers. It's about a 6-week process or so. So they're doing it now. And even if Congress acts, there's going to be a latent period where the new fee schedule, which is lower, is loaded. And say, like last year, they just decide to kick the can down the road and don't change anything. We're still probably looking at the bulk of January now, where either we get reimbursed at these lower rates, or you hold your claims until February. Last year, what happened is if you put your claims in earlier, CMS made it very clear that they didn't have enough money in the budget to reprocess claims. So if you got paid at the lower rate, that's what you got paid. they wouldn't reprocess your claim. So most people kind of got the heads up and were processing claims in February at the regular schedule. So for us in private practice and running a small business, you're talking about a January with potentially no CMS payments if they change it, or 20% reduced payments. We have to pay payroll every 2 weeks. We have to pay our rent. We have to pay all the normal expenses we have. So the buffer usually comes out to be, the immediate buffer is usually employees or physician salary. Those are usually the two flexible budgets that you have. So this is going to have a significant impact very early on for private practice in particular.
Dan, this came up in the chat earlier, and I'd like you to see if you can make it clear for the folks on the call who own practices like yours, own buildings. You're getting hit with the conversion factor affects the technical work RVU the same rate as it does the professional. Is that fair to say?
That's correct.
And then the clinical update is actually not built into that. It's a whole added feature. That's why the OBL hit is dramatically worse. Is that correct?
That is correct, yes.
So you really, people out there who are watching, they really need to advocate on both fronts, because you're going to take it on both ends.
Right, and for most people that own and operate OBLs, the startup costs for the OBLs are amortized over a period of years. And I always say, we talk about 5 to 10 year money. So we've promised. Sorry about that. Hold on a second. We've promised money for the next 5 to 10 years, and now we're faced with a 20% cut. That obligation doesn't go away. Many of us have personal guarantees on this money, and it's fairly onerous what we're looking at. And again, regular businesses, not medical businesses, facing a sudden 20% cut in their income, as far in the future as you can see, that's a pretty dramatic change, and affects your ability to pay your debt service and keep people employed, buy equipment, et cetera. The equipment's really not optional, because as a kind of laughingly use the example, it's like McDonald's saying, well, it's too expensive to buy hamburgers to sell to people, so we'll just not sell hamburgers anymore. I mean, it's really your business model which is caring for people, and you need the equipment to do that. So I mean, it's a big impact for us. So
along those lines, to take the talk about where the money's going a little bit further, there's a question in the chat. Maybe Matt, this might be, you start with this and then throw it where you think it needs to go. But these cuts are all based on what we're used to seeing, right? Work RVUs or RVUs if you own the facility technical component. How is this going to change DRGs for hospital? Like, is that being affected by this at all? Because the hospital you work for is going to still get a big lump sum of money, and maybe that's we get any break on that side from our employers.
So I'm glad somebody put that up in the chat, because the hospitals seem to be immune from the payment cuts that we have to burden year after year. With Medicare, hospitals are paid through Part A, and that seems to go up every year. I think they're looking at a +3. It usually averages out to +3, +5. So the hospitals aren't suffering in this the same way that we are. We are getting squeezed, and we continue to get squeezed. And that plays into the question of, it seems like we're facing this year after year. For those of us with the gray and white beards on this call, we may remember early in our careers, the days of the SGR, where it seemed like the function of the then Health Policy Committee was to rile up the base every year to reach out to Congress and say, oh, the SGR is going to cut us 5%. The SGR is going to cut us 9%. The SGR is going to cut us 12%. And it was a yearly battle for more than a decade before legislation changed that. But what we're dealing with now is kind of a byproduct of that. So the same kind of economic factors that drove the SGR are coming back to roost on us again. They're just coming at us from multiple different directions. With the SGR, it was a single spigot. All the control was on the conversion factor, and the SGR just changed the conversion factor. As you see from what we've got today, You're getting conversion factor from this side. You're getting sequestration from this side. You're getting supplies and equipment from this side. You're getting clinical labor staff from the other side. And then, oh, by the way, there's pay-go behind that. So we're getting 5 different types of cuts all kind of piling on to us at once. Kind of expanding on that, I've seen in the chat a couple questions about what about the ASC? So ASC payment is paid based off the hospital outpatient payment system, which is a slightly different payment system than the fee schedule that we all get through for Part B. ASC payments by design and by formula are going to be lower than the hospital outpatient payment itself. So it's roughly 60% of a hospital outpatient code. Those are all, it's going to vary code by code, and a fair number of those are also going down. So you're not necessarily better off flipping over to an ASC model. And for people out there who are thinking about that or talking about that, I would remind people about 5 years ago when the dialysis maintenance codes all got bundled, and people that had been doing very well in an OBL with taking care of dialysis patients suddenly saw a precipitous drop in their revenue for that.
Mm-hmm.
A lot of the bigger places tried to flip over to an ASC model because when those bundled, they got lower payments for their OBL than they were getting in an ASC. The problem becomes that a lot of these codes are modifier capped, and CMS will cap them based on typical. So you may get that better payment in an ASC for the first couple of years. And I will say, going code by code through here, we're not quite at that tipping point where, oh, you can flip to an ASC and do better. But even if you do that, Medicare will look at these and they'll look at 2 years of data. And if they decide typical is office, they're going to cap you at an office payment, even if you're doing it in an ASC. So I wouldn't rush out and spend millions of dollars to turn your OBL into an ASC and think that you're going to be safe, because you could spend all that money up front and then in 2 years get capped at the lower office payments anyway.
Yeah, and that's a good point, Matt. And, to convert to an ASC, there's depending on where you are, obviously state regulations, local regulations, et cetera, can be a fairly expensive proposition. And if you look at some of the reimbursement codes, yeah, they're higher for dialysis access, but they're actually less for some of the other ones as well. So you'd have to be very careful about planning your business model around that to recapture your investment.
I think Megan has the slide she wants to show. Like I said, it basically, is this the one that basically shows where all the money that's going to make this up comes
I
from?
can share this one.
And
Let's see.
it comes from physicians.
Here we go.
Right, that one. So Megan, I'm going to ask you the crass question based upon what Matt said earlier. Is it just that the hospital PAC is so much bigger than ours?
Well, hospitals lobby as the American Hospital Association, as the AHA, on block. There are sort of subgroups, the academic hospitals, et cetera. But ultimately, the House of Medicine has not hung together and advocated together in that way for an awfully long time. And it shows. Ultimately, I think that there have been some questions that have come up in the chat about collective action, collective bargaining, unionization. It's interesting that those are things that were discussed probably 20, 30 years ago, haven't been discussed a lot in the interim and are being discussed again. So I think we are at this crossroads where all of those things are on the table to be discussed. And part of it has to do with figuring out how we message for physicians. All you have to do is look at this table and recognize that far less charismatic creatures than the vascular surgeon, who, as we all know, is to the hero of the hospital, and to a large extent, the glue of our healthcare system, are getting their message out more effectively than we are. And we have an incredibly good story to tell. And I think we're underselling, for instance, the Surgical Care Coalition when we say that, we're really in there just for the common things like the conversion factor cuts. When we actually got on their last town hall, their last webinar, to talk about the impact of COVID, the impact of this rule on what vascular surgeons are doing in the OBL, the story we got to tell was of vascular surgeons who, when the big university hospitals, big urban centers were absolutely shut down. We're able to keep life-preserving dialysis access functioning. We're able to keep addressing CLI in, a little bit more nimble, a little bit lower touch, and certainly lower cost setting. And that is something that's been invisible to a lot of the players in the healthcare system, including a lot of our policymakers, and shouldn't be invisible to payers. So I think that our message is valuable to all of our coalitions because it's a good one. We know that this is what we do, all day long, every day, and it's good. So I think that it's time for us to get that word out there. And we've got to bring our line up to be a little bit like our friends and neighbors here. We can't be the only line that's dropping over 20, 30 years.
But some of that line equalization, like they said earlier, that means that somebody else is going to have to give, right?
Well, there's a lot of money in healthcare spent on things other than healthcare. We talk about things like prior authorization. We did a pilot with one of our payers that basically showed that a little bit of decision support and basically calling a truce on prior auth around advanced imaging, for instance, saved both the payers and us a lot of money and wasted time. So we're saving FTEs for physicians, advanced practice providers, nurses in the clinic, doing these peer-to-peer calls and filling out paperwork. And they're saving this entire sweatshop that they use to ultimately, delay and deny care from our perspective. And we're basically bilaterally disarming a little bit, and we can redeploy that money to actually provide care for people rather than, playing this absurd administrative volley. There are so many areas that we're doing this in healthcare. And when we look at our administrative overhead and the ballooning of our administrative overhead in the healthcare system over the last 20 or 30 years, we've really been, if you look at that, if you think back to that slide, the area that's absorbed a lot of the cuts, just as we're asking vascular surgeons and a handful of specialties to absorb this clinical labor update. There are other areas of the system that can absorb some of this, and ultimately, it just may be that we can't be held flat or cut anymore. It's a separate conversation.
I think those are all good points, Megan, and it brings up some of the theories of the point of where is the country going and where is Medicare going with payment. We're in the middle of a shift from pay for performance to pay for quality, but it seems to be kind of stuck in first gear. It's been a slow transition. With the forever joke of, well, how do you define quality? But I think everything we're kind of experiencing is a little bit of the pain and the slow transition away from getting paid, per widget for each thing you do, to getting paid for quality patient outcomes. The conspiracy theorists out there would say, well, these cuts are intentional and they're aimed at driving down and tamping down physician payments and getting physicians under control so that they can switch us to a payment system that's preferred. But if there's some miracle cure physician payment plan out there, I've not been aware of it. There have been multiple things tried over the last decade. And really, it seems like the only thing that's gotten much traction with CMS has been some of the accountable care organizations. But beyond that, some of the alternative payment plans that have been proposed have not had many legs and have not gone too far.
Yeah, well, Matt, that's a good point. And over the last 30 years, at least, since I've been practicing too, I think the physicians have been very cooperative with a lot of the efforts to control costs through the Medicare system. And, the reward is where we are sitting right now. So, at some point, you have to say, this is just not sustainable. It doesn't make sense for us to commit so many years of training, expertise, our availability, et cetera. And then, to turn around even after this, major pandemic, which a lot of us really struggled through, and to say a grateful nation wants to pay you less now. I mean, it's just frustrating. And at some point you have to stand up and say, maybe we do walk away from the table like every other, negotiation goes on. I think the lesson for CMS over the years is no matter what we propose, they still keep doing whatever. So why not?
Well, as been pointed out in the chat, is they've created a really pro-agency system, and it has to do with budget neutrality, where the expenditures from one year to the next can't increase by more than $20 million. That's the cap, which for a system that's paying $1 trillion a year, that's a drop in the bucket. So a small little variance in that causes a reshuffling of RVUs and a reshuffling of payments for all the codes to offset that, and thus we're the losers this year, where we're facing significant cuts. And so without lifting or changing budget neutrality or putting more money into the system, we're constantly in this mode of having to fight other people to avert our specific work from taking significant cuts. And beyond that, the system that's been created, the RVUs, most hospitals use those to base physician payments off of. So, going back to is the hospital, at least is our hospital partner doing better? Well, sure, the hospital partner may be doing better, but if you're an employed physician in a hospital, I'll bet one of your metrics is RVU productivity. So if we have the budget neutrality with the fee schedule, and we get hit with losing money from the codes we're producing to offset and pay for increases in other areas, well, that translates to a reduction in your RVUs. So if you do the same amount of work this year as next year, your RVUs will look 10% less because of the cuts that affect the revaluing of those codes. And so your hospital that's employing you is going to look at you and say, oh, well, you did 10% less work this year. You didn't meet your metric. We're not going to pay you your full salary, or we're going to renegotiate with you. And it's the same for people that are taking private insurers. A lot of the private insurers, they don't want to reinvent the wheel. They're going to set up their payment rates as a percentage of Medicare. And so they're going to just tie theirs to what the Medicare payments are. And if budget neutrality keeps driving payments down, well, I mean, that's easy for the private insurers. Hey, they get to pay less for what they're doing. And hey, it's not our fault. We're just paying you a percentage of Medicare. It's Medicare that's driving it down.
Yeah, that's exactly right. That's the hidden danger with this too, is other people say, well, I guess that's the going rate. So, and I think hospitals ultimately, when I get paid $35 an RVU, I have to take all my overhead out of that. So effectively, I get paid, with the 50% overhead, I'm getting paid at $17 an RVU. Hospitals do sort of the same thing. They make people whole by shifting monies around from what they get for the procedures themselves. As their amount reduces, then they'll probably be less generous with everybody as well. So that's why this is going to affect everybody. It's not just a private practice issue. It's everybody's going to get affected by this significantly.
These are great points, Matt. I'm sorry. There's a question, and I think Sean was actually one who said he was willing to grab the third rail. And I think since we're talking about specific reimbursements in different arenas, I think this is probably a good time in the chat to talk about this. So Sean, you agreed to handle this one first, but everybody can chime in. But obviously, I think in our small world of vascular surgery, there are some people who think that this is probably happening to us because we've been abusing certain codes. Is that true, and is there a way that we can do a better job of managing our fiefdom of procedures so that we're not seen as an outlier and driving?
So there's been a lot of discussion about outliers at our SVS national meeting with Kim Hodgson's presidential address from everybody in SVS Connect. That's really not driving any of this. So if you look at where we talked about, PAYGO's 4%, sequestration's 2%, those were set a decade ago. Right. Everything else is in the CMS rule in terms of our conversion factor and all these other things. And so, we need to control our own house of medicine so we're doing the right thing for our patients. All these draconian cuts have zero to do with that. We need to control our own quality and our own things. But at the end of the day, if we don't have money to pay ourselves, as Matt just said, if you're paid on RVUs, you're great this year, but as soon as your contract comes up and now you're paid less and we get paid less per RVU, we're all going to make less money. If you pay for your entire private practice right now, like Mark Matus does or Dan McDevitt does, guess what? Coming April, your first quarter comes and you're now getting a bunch less money. You got to cut people. And so, I know everybody worries about, the 1%ers that are doing things that aren't indicated, but this has really nothing to do with it. We need to police ourselves. But right now, all of these cuts are affecting us irregardless of all those issues. And I don't think CMS is smart enough to single out just us based on that, because the labor updates were because they haven't updated in 20 years. And we don't want to say we don't want to pay our people more. But the reality is we've been paying our people more for the last 20 years. And because it's a balanced budget and budget neutrality, when you pay your people more and now the pay scale's higher for them, the only thing that can come out of it, those of us that have high cost prices. So if you're using procedures in your office-based lab, you're paying for balloons and stents and atherectomy devices. Those are high cost items. And so they're not going to go down in cost. So your pay is going to be less. And so, I agree. We need to do the right things for patients, but there's nothing we talked about today that's a result of that.
And I think that's the point I was hoping you would make, which is there's nothing to do with atherectomy, right? This is something we all have to be together to fight, or else we're all going to sink together regardless. So
we don't do any atherectomy in the office-based practice. We do fistula interventions with balloons for the most part, and with ultrasound guidance, and we do varicose veins treatments in the Cleveland Clinic. But I have 2 office-based labs, and that's going to crush the budget to do that. And then I won't be able to support that. So I'm in an academic practice that's very different than many places where I am both the hospital and the practice. But, whether you're purely academics, purely private practice, or somewhere I am, there's none of us that are not affected by these cuts.
I would say my partner gives direct testimony that Dr. Leiden is draconian about supply costs.
Yeah. But that's true. A lot of these things, and that's why I think Medicare adjusted some of these things, because they thought they were overvalued in terms of what the market price is for certain equipment. But one of the things they do is they sort of make this sort of a statistical type of exercise. None of us see a statistical sample of patients. We just see who comes in our door. So we don't see thousands of patients or hundreds of thousands of patients that amortize or distribute this risk over. So a patient that requires a lot of equipment or time or whatever can be fairly expensive for us. And, we just have to go one at a time. So, meanwhile, Medicare just does it as statistics on a spreadsheet. So it's really frustrating because it doesn't comport with what we see in reality.
I think one of the things that everybody on this chat should understand is that this is going to take a lot of work in the next 6 weeks. And you have to assume that members of Congress and CMS do not understand totally what we do and the effect it will have. And we really need to push forward aggressively and basically educate them. My partner, Rob Molnar, put in a chat about he contacted our state senator, Debbie Stabenow, who didn't respond to him by all report, after Rob did an explanation about why the OBL is valuable, and to Megan's point that it actually saved people's lives because you couldn't get in the hospital, and that the OBL was your only alternative for at least 5 months for critical limb ischemia hemodialysis. They do not understand what we do and what we're facing, and that's our job collectively, not only this task force group, but to get the message out to everybody on this town hall, is to move forward collectively. And I think the slides reflect that, but you have to go in with the idea that they don't understand what we do. We're speaking to the choir here, all 150 of us. There was 280 that signed up. So, but it's going to take some work. It's not going to happen overnight. It's not going to happen because somebody else does it. Each of us has to be an advocate for ourselves and for the specialty. So.
Somebody made a good point in the chat, Mark, and I'm going to go back to you on what you just said, because if I know you pretty well, I bet you run as efficient, lean, and appropriate of an outpatient practice as there could be. And I think Medicare, this is actually not me, one of the chat persons said, Medicare doesn't understand if they're going to drive business out of your lean machine, they're going to drive it into a much less efficient place, which is the big hospital system, right? So can that be a part of the advocacy, is trying to help them to understand the actual effect of what this is going to do?
Yeah, I think that's a great point, Ben. It is. So, for example, if a percutaneous declot, I'm just going to throw this out there. So, in our situation, if somebody calls at 8 in the morning, it takes 40 touches to get them as an inpatient to get a declot, and it won't happen until about 6 or 7 o'clock at night. In an OBL, in our place, with that Dr. Molnar started in 2005, it takes 13 touches. That's it before they get to dialysis. And it costs 4 to 5 times more money to go to the hospital for a greater delay in care. Now, if you asked your congressman and their House staff and CMS, did you know that? My guess it would be no, they don't know that. And to our point is that you have to bring the message to Congress, bring Congress to you, to the OBL, to have this discussion. Because I just think they look at overall dollars and cents and have no idea about the human component, either as a patient or as a director, owner of an OBL, where you're employing multiple people. I mean, to Dan's point, right? I mean, if at Michigan Vascular, if these cuts go through, we won't feel anything for about 3 months, because that'll be the last quarter of the billing cycle comes back. So we won't feel anything, but we will in the second quarter, and we'll have to make some decisions, and it'll get worse in the third and fourth quarter. And you have to think about it from the human point of view, is that I got to lay somebody off, which means they lose money for a mortgage. They might lose their COBRA insurance. They might lose issues with their kids. I mean, the whole thing is, again, we get to the snowball effect. But every single procedure we do in the OBL is at least 3 to 4 times more expensive in the hospital.
But I think, Mark, too, we have to be realistic that the hospitals still are functioning at limited capacity. So the notion that somehow that everybody that's being taken care of in an OBL will find a spot to be cared for in the hospital, I think is incredibly optimistic. There's no personnel, cath lab time, OR time is very limited. I think there's going to be a significant number of people who don't get any care at all. And for dialysis patients, that may be a fatal event. That may be a limb loss event for others, diabetics, because I just don't think there's any capacity at the hospital to do the amount of work that we're doing in OBLs.
Yeah.
Mark, Dan, what's the possibility that folks like you all start to have to share some of the costs with the patient? So you want a claudication operation to live better. Why is that not like a lipectomy? And you figure out how much the difference is after these cuts, and the patient brings a check to make up the difference.
The Australian method, we're generally prohibited by the contracts we have from balance billing patients, or billing on beyond, especially with Medicare. For a covered service, that's really not done. And I know there was a remark on the chat about you don't have to participate in Medicare. It's interesting.
More politely, that's
it's interesting. If you want to opt out of Medicare, it's even more paperwork to do that. And you have to kind of continually certify what you're doing. And then you can charge patients 105% of Medicare, I believe. Those are still the rules. But Medicare only reimburses something like 75% or something like that. So the patient's responsibility actually is quite high. So.
Yeah, the other thing that I think we all have to understand is that the private practice players follow Medicare's lead. And it's not going to stop with just Medicare, it's going to go to the private pay.
And for us, Medicare is 50% of our business. I mean, it's a pretty big footprint.
I think from a moral and ethical point of view is that a lot of people talk about getting out of Medicare and just going on strike. And if you think about it, it strikes to the heart of why I'm a vascular surgeon, right? I don't want to have to change my ability to care for people because I'm not getting reimbursed, or there's limited nursing and there's limited space in the hospital. I mean, I want to save life and limb. That's what I became a doctor for. And yet that's being challenged because I believe that there's uneducation within Congress and CMS about what surgery does as a whole and the value it has to the community and national health, which I don't think it has been described very well. And I think that's part of the problem. A healthy community is a healthy city. A healthy city is a healthy state. A healthy state is a healthy nation. And we're missing that. And so
I just have to call out again some of the efforts of the Surgical Care Coalition to do that. And there is actually the ability, if you go to the Surgical Care Coalition website, to participate in telling that story. We've had a number of vascular surgeons, most recently Misty Humphreys out at Davis, basically write op-eds that are placed either in Hill papers that are read by policymakers, in the local newspaper, to really explain to the public and our policymakers what we do, to tell the story of what our role has been over the last year or so, to explain to people that we see high risk, high comorbidity, frail patients longitudinally over the duration of their lives, things like that. So I think that we have never before made an effort to explain that broadly to the public and to policymakers through venues like the newspaper, like some of these publications. And there is an opportunity to do so. So you can go see some of the testimonials from other surgeons and vascular surgeons and see if you have a good opportunity to tell your own story or to add to that if you see things that are missing.
Megan, you give us an opportunity then to answer another thing on the chat, which is I think the people that are in the SVS membership, right? The SVS has been kind enough to host this and to have all these committees and advocacy groups because it's the only way for us all, I think, to be together and to work together. But the membership needs marching orders, right? That's what somebody wrote that exact term in the chat.
Careful what you ask for, Dr. Ryan.
Well, exactly. So do we have the bandwidth to get that to them? I mean, can we put out through Specialist or Pulse or Connect and get them what they need to do? It means a lift on the side of membership, right? I mean, like I said, it took me talking to you all to realize that all the different email asks for advocacy were different places and different things. I did one and I was really proud of myself when I went back to doing cases, and there's more to do.
Yeah, I'll pick up that ball there just to answer some of the questions in the chat and housekeeping. Some have rightly pointed out that our voter voice was still set up for some of our other issues. That is now corrected, and so I'm told that the voter voice is loaded and ready to go with pre-set letters to your individual congressmen, specifically about cuts affecting vascular surgeons. So thank you all for that. There's also been some other questions about are we collaborating with other people in this, and I have to say we've had an impressive advocacy effort since July with this. Again, we thank our friends with Surgical Care Coalition, and they're doing a lot of the heavy lifting with the more global conversion factor relief, which has enabled us as the smaller, more direct groups affected by the supplies and labor, the supplies and equipment in the clinical labor update to work with other like specialties. So we have some pretty broad coalitions, including interventional cardiology, interventional radiology, American College of Radiology, American College of Cardiology, that we've worked with the Cardiovascular Coalition. So we have found and reached out and collaborated with other specialists and subsets of other specialties that are going to be equally or similarly affected by these cuts with us. And in this clinical labor coalition, we have gone and knocked on and talked to everyone and anyone and everyone who will listen to us, including CMS. We've talked to Congress. We've talked to the White House public outreach committees. We've talked even to the Office of Management and Budget about the cost of some of this stuff. So we have been very active in this, and we're fighting hard for our members. I did see a question in the chat earlier about there's so many different cuts and different buckets. What can we affect? What can we expect some motion on? And I think that's an excellent question. I think our best approach is going to be the conversion factor relief. I think it is fairly reasonable to expect that we can get some motion on that. And that's kind of what our lobbyists from DC are telling us, is that we have a good chance at getting an extension of the relief from the conversion factor. So that's 3.85%. There's a potential little cherry on top of that, is there may be some appetite from Congress to add money on top of some relief to not reverse the clinical labor updates, but to lessen the impact of that, which would be fantastic as well. The supplies and equipment, that's that final year of 4% update for supplies and equipment, that is fixed. So that is not going to go away, and I don't want anyone thinking that can go away. The only good news about that is that this is the final year for that, and so that will be set and fixed moving forward. Sequestration, I think we can potentially get some traction on and get the moratorium on the sequestration extended. PAYGO is tricky, right? PAYGO has a lot more to do with what Congress overall is spending and doing, and a little less on what we're doing. But that's definitely something else that we are working on.
Friends shouldn't talk politics, Matt, but when Congress spends more, it hurts those of us who rely upon, right?
Yeah, exactly.
So our Congress people need to understand that there's votes tied to some of this too.
Well, I heard a really good point. I think it was Dr. Schutz that made this when we were doing our fly-in. The sequestration, you know, they've been kicking around trillions of dollars for infrastructure bill. I think 1.7 was what finally got passed, but they're looking for a second round of a spending bill. Well, our 2% sequestered Medicare payments, they're already eyeballing that as pay for these spending bills. So talking with some of these Congress people with this past summer with Dr. Schutz, he said, how can you not think of healthcare as infrastructure? What's a more critical portion of the part of the infrastructure for our country than the health of its citizens? So why are you stealing money from healthcare to pay for infrastructure while you're hurting your infrastructure from the healthcare side in the process?
Well, there's your letter.
There's your letter.
I love it. Matt, is there anything else you want to cover tonight?
One more housekeeping. In one of the QAs, I saw somebody asking if there's an available CPT code by code list of what the percent effects and impacts are. We do have one that we're working on. It's not quite clean for sharing, but I have a promise from our staff that they will have a clean code by code searchable spreadsheet posted onto the advocacy page of the SVS website by Friday.
So I think the other thing is that SVS Connect, we're spending a lot of time looking at that. And so if people want to ask direct connections in SVS Connect, we'll do our best to try and get those answered in SVS Connect so you can share them to everybody else. And when you reach out to Congress, the more personalized your letter is, the more effect it has.
That's great, Sean. Mark, anything you want to say in closing?
Yeah, I just wanted to say thanks for everybody who's got on the line, and I will make a plug for the PAC, of which I am a co-chair. Your participation in the PAC gives us opportunity as a specialty in a society to get in front of Congress one-on-one to talk about these issues. And there's nothing like face-to-face contact and conversation that can help sway the conversation in our favor. So please donate to the PAC. Talk to your partners, get them involved. You know, we would love to have 30% of the SVS, of the 4,000 members, to join in the PAC, contribute whatever money you can. Let's move this forward and, you know, help us out.
How much do you think that somebody's asking how much, I mean, it's hard to put a dollar on it, as much as you feel like you can give, right?
As much as you feel like you can give. We would like, a lot of money, but we like bodies. We want to have people engaged and advocate so that when we talk to them, you can give as much as you want, up to $5,000 per year or $100. It doesn't matter. We need bodies.
Dan, any last thoughts as the small business owner?
Yeah, if you want to know how much to give to the PAC, just think of it this way. If you're going to be a practice for the next 20 years and you're going to lose, say, 20% of your income this year alone, multiply that amount by 20 years. And that's, the kind of like long-term effect of this. That's probably a substantial amount of money. So to give a fraction of that to the PAC and try and, prevent that from happening, sounds like a pretty good return on investment to me. So.
That's great. So Megan, I'm going to be working with you that next 20, 25 years. You pointed out to me an email last night, and nobody knows, I think, in the SVS more about how things actually get done on the Hill. Anything you want to give people to take away from tonight?
Yeah, I mean, I think that we've looked at what's happened over the last 25 years and talked a little bit about how sustainable it is. This is really an investment in the future of our specialty and in the well-being of our patients. So incredibly, incredibly important to put a stake in the ground at this point and invest in the future of the specialty. So I did also have to give a shout out to Trish Grishak and Jill Rathman, working with the SVS on the staff side, who pulled an all-nighter to go through about 2,300 pages of rule and get those tables and all of that data out within 12 hours of the rule being released last week. To Mark Madison, Peter Conley for the record-breaking month for PAC fundraising and a ton of work this year. And I think it's a really, for a relatively small specialty, very well represented in digging in on behalf of everybody and their patients going forward. So it's going to be a busy 6 weeks, but I anticipate longer than that, probably a little bit longer horizon for the bigger fight. So.
Well, and let's thank you so much, Megan, for that. And you bring up a great point, which is Tricia, Ken, Debbie, Tara, Lynn, Kristen, all the folks at the SVS who have made this happen and continue to fight for us. We all thank you, and thank you for giving us this forum to do it. Matt, I really appreciate you. I always have, as a friend and a partner, but being a leader in this for us. And thank you for letting me be involved. I've learned more tonight about things that are important to me than I have at any other point on these issues. So I want to turn it over to you for the final word and say thanks for all you've done.
Well, thanks you, Ben. Thanks for being our host and MC tonight. You were the first person I thought of and the first person that the SVS thought of. And so I knew it was a perfect fit. And I want to say thanks to everyone who took time out of their Wednesday night to listen and give us some great questions to answer. If we didn't get to yours, we will make sure we answer those in writing afterwards. And I want to thank all the panelists that helped prepare for this and answer and participate tonight. They make my job as council chair and chair of the task force easy when they've got great people to work with that are really dedicated and hardworking with the same goal in mind. So I hope everyone that was on tonight can see how passionate we are about this, and that even though what we are facing looks daunting, we're still optimistic, and there is a lot that can still be done. So I would just encourage everybody to get involved, to contact your congressman, to donate to the PAC, and to tell your partners and to tell your colleagues, hey, what are you doing about this? Help, chime in and help. Don't just be the guy sitting in the surgical lounge complaining and not doing. So, get up and pitch in and help for all of us. And I guess the last word is good night.
Thanks, everybody.